So I've got the topic of, of non-involving, non-surgical management of pectus deformity. Just to point out to the audience, this was never decommissioned. It was always something we could provide our patients, and one of the biggest frustrations is I think we kind of missed the boat slightly when it got decommissioned, that we kind of stopped seeing patients with pectus deformities. We felt there was no options for them. There's always been options for them, and non-surgical options have always been on the table. So that's one of the frustrations. Quick disclosures and some acknowledgements to Abdullah and Akshay, who helped me with some of the data collection. So we've touched on pectus deformities, what it is. Historically, surgical correction has been the standard approach, but there are non-surgical options for our patients, which are less invasive and potentially offer benefits. So what are those non-surgical approaches? Well, exercise and physical therapy. Physical therapy programs aim to enhance muscle tone and optimize overall chest wall mechanics. It is an unconsidered non-surgical option for our patients, and I do think it needs to be focused on, particularly when we're dealing with both non-surgical and surgical patients. External bracing. So hopefully a lot of the audience will be aware of the role of external bracing. It's a very effective treatment for pectus carinatum, and we'll talk a bit more about it in a minute. And then finally, vacuum bowel therapy, which is a less understood non-surgical treatment option, which can be challenging. But with careful selection, it does offer our patients benefits. So exercise and physical therapy. So it's offered in patients with excavatum, carinatum, or mixed deformity. It's the association of posture and changes in muscle tone associated with our patients. So one of the things we're particularly interested in is, and I was chatting to Carl Davis about this, is our pectus patients have a morphology associated with them. We all recognize it. We can spot them in the outpatients waiting to see you in clinic. They're tall, they're slim, they have a low BMI. They often have many posture elements which can be clearly identified. And with the help of our physical therapy services, we can support them in terms of managing some of those challenging posture problems that we see. And we're very much focused on the non-surgical treatment options, combining physical therapy with bracing or vacuum bowel therapy, but there's no reason why we can't focus our attention on patients having surgery as well. So, exercise and physical therapy, the evidence. There's very limited studies, and when you search for evidence around physical therapy in supporting patients with pectus, you often immediately come across a lot of studies looking at cardiopulmonary exercise, for example. So it's actually quite a hard group of papers to identify. However, there has been several. Mustafa Yüksel and Alkan Alka, who are a couple who are physical therapists that work with Mustafa in Istanbul, have done some limited studies on the role of physical therapy in the context of non-surgical treatments. And specifically, they published a small study looking at around 30 patients who underwent vacuum bowel therapy and were supported with formal physical therapy and non-formal physical therapy, and they showed benefits. Same group also looked at compression bracing. Again, small numbers of patients. And again, in a small number of patients, around 30 patients, they were randomized to group 1 to have bracing with physical therapy, formal physical therapy, or not. And again, they demonstrated some improvements both in the physical aspects of the patient's posture, but also the psychological well-being in terms of the success of that treatment. So there's definitely something to consider in relation to exercise and physical therapy. Now, so we introduced our physical therapy as part of our program for pectus deformity in terms of bracing explicitly, but also later introduced it for vacuum bowel therapy, and we've really focused on that as part of our practice. Now, in that regard, this is the issues that we've found. So we looked at around 1,100 patients who were either having bracing or vacuum bowel therapy, and we demonstrated around 2/3 of those patients had a recognized posture-related issue. And this is with the support of physical therapists identifying those particular posture problems that we see. So it is clearly a problem with our pectus population. What sort of issues do they have? So the most common thing we were seeing, text neck. So this is kind of a description of patients where they've got a forward head. It was a common problem we saw in patients with pectus deformities. Other types of physical aspects we saw were related to the presence of thoracic kyphosis, the relationship between thoracic scoliosis, which the audience would be aware of, but also lumbar lordosis. One of the most common problems we also saw was rounded shoulders. So we were able to identify explicit posture-related deformity associated with our patients, which were labeled and identified by our physical therapists, which we could focus on. Final thing is pelvis and abdomen. We saw occasionally patients with what appeared to have a pot belly. Often they have anterior pivot rotation issues. And finally, rib flare. So these were specific things that we are able to identify in our patient group that we could focus on in terms of providing some physical therapy support. So what we did was we looked at the data that we had. This is focusing on patients who had external compressive bracing, and we were able to identify the specific groups of patients who were given guided physical exercise pre-COVID, that was with physical therapy support. In COVID, it was more patient-orientated, so the patients were given groups of exercises which they had to do as part of their program, and we identified variations and improvements in some of those posture issues, explicitly around things like neck issues and shoulder issues. These are the groups of exercises that we focused on. We focused mainly on posture with rounded shoulders, so what we could describe as generally thoracic mobility exercises. And then we focused specifically on core exercises, and this is the exercise programs that we gave our patients. And so fundamentally, we were able to demonstrate that these sorts of exercises do improve patients' experiences and physically improve their issues with their pectus in combination with some other form of treatment. And in our groups, it was non-surgical treatments. So that's something I would emphasize in my colleagues who are interested in this particular work. Involve your physical therapist in your practice. It's been very beneficial to our practice. So moving on to external compressive bracing. So this is treating patients with pectus carinatum, with mixed deformity, and with rib flare. We use various types of custom-made external braces. We apply external dynamic pressure using pressure gauges or not. And the idea is that you gradually reshape the young person's chests. It can be applied to both chest and ribs. And these devices, these orthotic devices, can be manufactured through whoever your NHS provider is, and they provide a very straightforward approach to managing pectus carinatum. The evidence, it's been out there for a long time. This is a publication from the American Pediatric Group published in 2012, which was saying fundamentally pectus carinatum in young patients with flexible chests, bracing is the standard of treatment. So it's not new stuff. There's been some developments, particularly as Carl will be talking about later, in relation to the fantastic pectus service provided by our Scottish colleagues, and they've made some very important keynote elements to the bracing program in their program. So, Carl will tell us a little bit more about that later. And there has been some studies. We ourselves did some studies around the role of pectus carinatum, and we ourselves did a literature review of it. And what I took from those studies, including the study we were involved with, was assessing the patient, selection of the patient, the types of protocols, the duration of treatment. These are the aspects that we looked at as part of this review that we did. And obviously the most important thing is flexibility. So these are young patients. So by definition, they have a flexible chest wall. And we sort of beyond the scope of this talk, we can talk about how you assess that. Severity, all types. The severest pectus carinatum in a patient with otherwise flexible chest wall can be treated with bracing. So there's no restrictions on the severity of pectus in terms of treating it with a brace. The types of pectus, important that you treat a pectus which is below the level of the nipple. So fundamentally, the superior pectus carinatums make bracing extremely challenging. Otherwise, it's below the level of the nipples to treat patients with braces. Compliance is key. That's rather obvious, but it's super important that your patients are motivated to wear their brace. The schedule that we adopt is a very intense schedule, so you start with a very intense schedule, wearing it fundamentally all the time, and then you wean the brace off over a period of time. It's better to do it that way because you'll get patient buy-in. They'll see their chest correcting, their intensity of the schedule is based on the fact that they feel like they're getting better quickly after a few weeks, and then they buy into the rest of the program. And our programs are usually based on around a year in terms of the treatment. There is quite a lot of variability in the literature about that, but we base our program on a year. Outcomes are good. They do well, and it's a very effective treatment. And I strongly recommend, if you're interested in Pectus, if you're seeing young patients with pectus carinatum, this should be their first-line treatment, fundamentally. And complication rates, they're low. They're fundamentally the risk of skin issues, which occasionally can present with a pressure sore. So that's the most severest forms of pressure issues that we see. But thankfully, they're uncommon, and with careful management, can be managed. So this is our experience. So the first pie chart is patients who have undergone compressive bracing over a period, including COVID. So we had less access to our patients during that period, and it's based on some data I presented with Akshay back in 2019, which we've extended on. And it demonstrates the sort of patients we're seeing. So majority are male, and the age range that we're seeing. So it's not under 11. It's actually our age range works out as a median of around 14 to 15. So it's actually slightly older patients. And that probably reflects a little bit about our own practice, but also reflects when patients start noticing they're developing pectus carinatum. So it's often a bit later than you realize. So that's our typical age range. And obviously, it's aimed at children. So it's aimed at the young age group, which reflects the fact that flexibility is absolutely important in terms of offering braces, which will work in terms of the success we can achieve. So reporting family history. So this is a little bit of demographics around our patients. Again, it kind of supports the literature that we were finding around 68% of our patients didn't have an obvious family history. As you know, the pectus genetics is quite complicated. It'll often skip generations, and it's not a direct lineage in terms of the genetic element unless you have a syndromic association with your pectus. But roughly 25% of our patients were reporting some degree of family history associated with their pectus. When they presented, as I touched on, a lot of patients are actually presenting later than you realize. So typically our average age would be 13 to 15 in terms of the presentation. So it's not when you expect. And there was a small cohort of patients presenting essentially at birth or within the first year, which appeared to be in some ways slightly different from our average patient presenting at 12 or 13. So there's a slight bimodal distribution of presentation of these patients. And I feel that they're slightly different in terms of the nature of their pectus. So this is slightly busy, but it demonstrates the sort of deformity that we're seeing in the context of pectus carinatum. So the most common form of pectus we see, which are being then offered bracing, are the lower pectus carinatum deformities. So typically 80% of our patients have symmetrical deformities, but it does mean we have a significant number of patients, around 14%, who will present with an asymmetrical or lopsided pectus, and which are still appropriate for bracing. Now, your brace needs to be better designed, and you need to focus a little bit more on the brace that you're using, but it still means these patients can be offered braces. It's not a contraindication to bracing. What measurements are we using to assess how well bracing works? Well, we measure our patients, and then obviously, as Joe was alluding to, satisfaction scores are super important as part of that assessment. So we demonstrated a way of measuring patients with pectus carinatum, and basically what we took was a Haller index and reversed it. So we came up with the idea that we can measure the pinnacle of their pectus carinatum, set up a kind of Haller index in reverse, so the closer you went to 1, the rounder the chest was. And what we were looking for in terms of outcomes was the more oval they became, so more towards 2 or 1.7 or 1.8. That's a simple measurement that we developed, which allowed us to then assess objectively how these patients were progressing in terms of their bracing programs. And this is a bit of a busy slide, but demonstrates roughly in around 300 patients, our early data, that we were able to achieve a significant improvement in their shape of their chests over a typical 9-month program with Haller pectus indexes moving from a 1.1, a round chest, towards 1.5, a more oval chest. So that slide's slightly busy, but it sort of you get the sense of an objective improvement in the shape of the chest using a brace. And then scores. How does that patient feel about themselves? And again, we were able to demonstrate their scores pre-treatment were on the lower side. They were generally unhappy about how their chest looked. towards a higher happiness score as they progress with the program. So again, demonstrating both subjective and objective evidence that bracing is a very effective and very useful treatment for patients when they're selected to have a brace, and that's really the flexibility element so important. So external bracing. So it's an orthotic device. You need to engage with your orthotic team in your hospitals. You need to create a custom brace, and again, your orthotist will be very familiar with making braces for many different things, so there's no reason why you can't be involved in that process. There's good evidence it's effective in young, flexible, selected patients with pectus carinatum, and it should become your first-line treatment for patients with pectus carinatum, and fundamentally it means surgery can hopefully be avoided going forward. And then we combine it with targeted physical therapy to try and approach this as a holistic approach to get the best results for our patients. So that's our experience. So moving on to a slightly more enigmatic device, vacuum bell therapy. It's aimed specifically at pectus excavatum. It utilizes a bell-shaped device that's placed over the pectus deformity, creating negative pressure, and these devices are designed to lift the chest. Now, I think when I first heard about vacuum bell therapy back in 2009, I was like, this is not going to work. This is nonsense. And quickly realized there's something to this treatment. But again, as always, everything we do in surgery is about selection. If you choose your patients carefully, this has some merits in terms of its treatment. So, first described by fundamentally Eckhard Klopp, but with colleagues around 2005. Eckhard Klopp, if you don't know, is a German engineer with pectus excavatum who developed this device, which has subsequently morphed into other people using other types of devices, but the fundamental design is based on his work. And there are really no current guidelines around it, which is interesting. There's no comprehensive assessments of it, which is, again is interesting, though. This is from Carl's website page, and there are some information out there about vacuum bell therapy. So we did a systematic review several years ago now, looking at the role of vacuum bell therapy in treating patients. And what we gleaned from that review was, and just to say, this is it's still ongoing, so you can still read about vacuum bell therapy. This is a paper I found published a week ago. So you can still read about vacuum bell therapy, but what we gleaned was from the systematic review, which I don't think has changed dramatically in terms of the 5 years since our systematic review was published. And what we gleaned was fundamentally this is for young patients. And unlike bracing, where I sometimes delay treating patients with braces because I know the brace can be effective up until 13 or 14 or 15 years of age, vacuum bell therapy generally should be offered as soon as possible. So if I have a 7-year-old or 8-year-old in my room, start then. So that's probably the big difference between bracing and vacuum bell therapy. Bracing, you can wait a bit if you wanted to. Vacuum bell therapy, start young. Flexibility is key. Selection, it's not for patients with severe pectus excavatum. It's not for patients with fundamentally what you would regard as a Halley index of greater than 3.2, 2.3. It's for more mild to moderate pectus deformity. Ideally less than 1.5 centimeters, though we have, if you like, pushed the envelope slightly. It's aimed best at patients with symmetrical pectus deformity, so the more straightforward pectus excavatum type deformities, though you can absolutely use it with asymmetric pectus excavatum in the right sort of setup. Compliance is absolutely key. Wearing a vacuum belt is quite uncomfortable, not particularly pleasant, and you've got to convince your patients that they have to wear it. So follow-up is super important. You need to see these patients regularly to motivate them to continue to wear it. It is watching paint dry. That's what vacuum bell therapy is based on. And if you do this sort of work, that's what you have to explain to young patients who have a different perspective on time. 2 years feels like 100 years. 2 years is the basis of our program. They have to understand it's going to take time. Wearing it as much as they can. So what we've found is if we can persuade them or try and make them sleep in the vacuum bell, 8 hours a day, roughly, that will improve the outcomes. Now, sleeping in a vacuum bell is quite challenging, and there are things you can do to try and support that, but it is quite difficult for the patients to do. Outcomes. patient management expectations, it's a reasonable outcome in terms of result. It's not necessarily going to give them a flat chest. If you are offering them surgery and you saw the result after a vacuum belt therapy, you probably find you'll be quite disappointed often in terms of the outcomes you achieve. But it can achieve some very good results. Clearly, the risks of this technique are negligible compared to a surgical approach. However, you do occasionally see skin issues. So for me, the long-term outcome still remains a little uncertain. But so far, in our experience, and we've got quite a long experience now of following patients up for over 5 years, I do think it offers a permanent correction. So what's our experience? So again, we find mainly it affects males, as predicted. Age distribution is interesting. I think it's even more bimodal than with pectus carinatum. And this is the age group of patients being considered for vacuum belt therapy in our own practice. Again, it's focused on the 13, 14, 15-year-olds because that's when they get their pectus. That's when they start manifesting their pectus deformity. Ideally, I would like to meet them younger. But they don't have pectus when they're 9 or 10 years old, often. They only start developing the pectus or becomes apparent when they get older. So that's our age distribution for vacuum belt therapy currently. Family history, interestingly, very much echoes pectus carinatum. Around 25% of patients will have a family history of pectus deformity. So it is an interesting note. And then the age distribution of patients first presenting it, as I mentioned, it's a little bit broader than pectus carinatum. We do see more patients presenting with pectus excavatum at birth or shortly afterwards than with pectus carinatum. I don't know why, but again, it's a fairly typical kind of bimodal distribution as we saw with the previous slide in relation to pectus carinatum. So yeah, similar kind of condition. We use the same sort of assessments as we did for pectus carinatum bracing, where we look at satisfaction scores, reporting the improvements in physical symptoms. That's really important, and that'll kind of it's kind of the reason why you'll see a few patients I've taken on where they have pectus carinatum excavatum, which is quite severe, but they may have physical symptoms associated with that severity. Remember, you are treating their pectus. Their sternum is being lifted by this treatment. So it's important to understand that it has that benefit. And then obviously objective measurements, which we'll touch on in a second. How do we assess them? So the slides on the left just demonstrate really what Joel was saying. The Haller index is not a great index for assessing of pectus excavatum, but it gives you a sense of what patients have when you're presenting them and considering vacuum belt therapy. You're fundamentally dealing with patients who may not be considered for surgery currently. So Haller index of 3.3 gave this patient a 22 millimeter pectus depth. And what we do in the clinic is we don't do a CT scan or an MRI for assessing these patients. We do a simple physical measurement demonstrated on the picture, which you could say is crude, but it gives us a sense of how severe their pectus is. So that's how we assess them in terms of measurements. And then, as I mentioned, physical symptoms are important to clarify. The assessment has to involve evidence that it lifts. It's a suck it and see treatment. You try it, and you try it to see if they lift. You have to get lift in that patient, and ideally we expect a lift of more than 5 millimeters from baseline. They have to tolerate it. Sometimes, particularly in the young children, and Carl might touch on this, they don't like it, and that can be a problem. And obviously, we've touched on severity. So the basis of our program is aiming our severity score of ideally less than 25 millimeters, ideally less than 20 millimeters in terms of the severity. So that's our experience so far. This is a group of patients that we've measured in terms of the pre-vacuum belt therapy treatment start, and about 90% of our patients are less than 25 millimeters in depth, Haller index of around 3 probably, or about 60% of our patients are less than 20 millimeters. So it's obviously aimed very much at the mild to moderate deformity. You'll see there's a few, I'm okay for time? Yeah, we can see there's a few which we've taken on which are much more severe, but in that group of patients, physical symptoms were a significant concern. We are not going to correct their 3.5 centimeter correctors to the point where it would look particularly visibly different. But I have had recently an experience where we corrected a patient from 3.5 to about 2.5 with improvements of physical symptoms. So it is sometimes worth a consideration if physical symptoms are a big part of their presentation. But generally, it's aimed at mild to moderate pectus excavatum. Very busy slide. It's raw data. It's demonstrating what we're achieving with vacuum bowel therapy in the group of patients, in around 160 odd patients that we've so far treated, and it needs further analysis, which I haven't had the opportunity to do yet. But a basic analysis is this: around 25% of patients, you do not get a significant improvement in their pectus deformity. In around 75% of patients, you will get an improvement in their pectus deformity. And that's as best I can manage in terms of the analysis so far. Clearly, it's any benefit, any improvement. So it doesn't necessarily mean they're entirely happy about it. But we do get a sense of how they feel about their chest shape before and after vacuum bowel therapy. And obviously, there's a general trend to feeling happier about their chest shape with vacuum bowel therapy in terms of the improvement they're able to achieve. And typically, they were scoring 3.5 on a happiness quota and managing around 7 after treatment. So that's how it works. Process bracing should say vacuum bowel. So vacuum bowel therapy, we understand how it works. We understand it's applying suction to lift the sternum. There's good evidence that it does lift the sternum. There was a vogue about 14, 15 years ago when you were going to these Pectus conferences where people would think it was lifting the skin, lifting the soft tissues. There's good evidence through CT work, and lots of surgeons actually using vacuum bowel therapy as their sternal lift device in theatre, that it does lift the sternum. There's no doubt about it. There's some evidence it's effective in young, flexible patients, lifting the more straightforward pectus excavatum, and definitely aimed at the mild to moderate deformity. And compliance is key. They have to wear the vacuum bowel, and they have to wear it fundamentally as much as they can. And if they can sleep in the vacuum bowel, it definitely improves their outcomes. But you also need to manage their expectations. It's not necessarily going to give them a normal chest. And I think that's super important. And again, if you combine it with physical therapy, you can improve their patient outcome experiences. So that's my take on vacuum bowel therapy. So last slide. Evidence, exercise and physical therapy should be offered in all patients with pectus deformity in general. External bracing, a selected group of patients, but it should be the basis of all treatments in patients with pectus carinatum. You should not be considering surgery in these patients unless they have an inflexible chest, which is often predicted by age. And vacuum bowel therapy is for a select group of patients with mild to moderate pectus excavatum who have otherwise a flexible chest. Thank you.
Ian, thank you very much. It's a very extensive experience, a fantastic result. So in Wales, we're doing bracing and we're doing a vacuum bowel, just to show the paradox of commissioning. So we are funded for surgery in Wales. We're not funded for bracing and vacuum bowel, so the patient need to self-fund. We have a large group which is let's say, managed by my colleague, Mr. Vazolgiu, with bracing. We use a vacuum bowel. What do you think about vacuum bowel as delaying the surgery for the young people? Sometimes we do.
Yeah, so started using vacuum bowel therapy in about 2012. And the conversation was, your kid's too young for surgery. Let's try this device. It probably won't work, but it was doing something. And then after about 6 to 9 months, the group of patients I started using this treatment with were coming back to say, actually, I don't really want an operation now. I'm quite happy. And I started to realize at that stage, it's a standalone treatment. So you change your whole approach to that patient and do not discuss it's a delaying while you're waiting for surgery. And you kind of change that approach, the philosophy of that conversation with that patient and their family. So now it is absolutely a standalone treatment, and it's not offered as while waiting for surgery. In fact, I was kind of alluding to it. John may be aware of this patient. It's in your neck of the woods, Margaret. And I've managed to treat a patient with a severe pectus excavatum, 3 centimeters, and I've converted him to 2 centimeters. He's now not eligible for surgery because his Hamler index is less than 3.2. It was probably around 4 when we started the treatment. A little embarrassing. His mother's keen. The boy's super happy. His physical symptoms are much better. It is what it is.